Hello, everybody, and welcome to the webinar on non-invasive ventilators and how they can save lives. I really appreciate the presence of all our speakers today, and thank you so much for taking the time out, especially first working day of the week under these circumstances where every minute of yours is so valuable. We think that this product is the need of the hour. A lot of places around the world, we don't have luxury of having the ventilators, leave aside talking about the importance of the ventilator in this current scenario. I want to start with our personal experience close to 27, 28 years ago when our daughter in Pakistan had a respiratory failure at the age of 9 months. And we went to the best institute in Karachi, and there was no ventilator available for more than 12 hours, and we had to manually bag her. And manually bagging her could have been very risky, but we were lucky enough. We managed to get her on the ventilator 12 hours later, and by the grace of God, she survived, she's healthy, and she's grown up. But I can already imagine in the developing world, and not only in the developing world, we have seen the outcome in the developed world like US, Europe, UK, that there was a huge shortage of ventilators. And when we got the call that ventilators actually are not always saving lives, and almost up to 80% people going on ventilators were not surviving, people did start looking at different options. And I'm so glad that the team working on this subject came across the non-invasive ventilators. When I was contacted by Mujib, who was leading a team who's working for Apple, and he called and talked to me about how they have worked with Subsal, with Dr. Patel and the team to come up with supporting a solution which could really be something that could help the developing world. And now, over the last few weeks and months, we have formed this partnership, seamless partnership of the Health Bank with Subsal in order to make sure this technology is and product is available to all the people in this region as quickly with as much support as possible in order to reduce the cost of it, in order to reduce the middlemen in between and people from profiteering and all that, but at the same time, find ways and means of delivering quality service to people who deserve. Health Bank is an organization, Singapore based originally, with focused on creating a virtual hospital, working in three verticals, which is telemedicine, telemonitoring, health and wellness, and home care and home monitoring. Now I'm going to request Mr. Michael Lombardi, who's joined us, who's the co-creator of this product as well. I would ask you to please talk to us about what is the Subsalve product that you guys have co-developed, and tell us how we can use it in this part of the world. We'll start with you. Thank you.
Okay, thank you, Raza. Good morning, everybody, or good evening to others. Very happy to be here presenting on behalf of Subsalve USA, who is the manufacturer of an oxygen treatment hood device. Raza, would you like me to walk through a short slide presentation to illustrate the device at this time?
That's great. Can I just take the opportunity right now, something that I think I should have done, and so I'm really not a professional in organizing webinars, so please excuse me, guys. I didn't really have a chance to introduce each one of you. So Mike Lombardi, and Mike can tell you more about himself, but at least I can introduce the name and the co-developer. I can see Dr. Naeem Lokmani has joined us, who has worked with this product, and he's been a part of the Humanity First. And of course, we are really happy that Dr. Bhakti Patel could join us as well, who has actually done the clinical trials and has been working on this product for many years. And Orica, who has worked, I'm not going to mention 6 years at all. So I'm going to say that she's worked for many years on this project, and she's been part of the Chicago University on the study as well, and she's worked with Dr. Baki Patel. And we've got Emma, who's based in Dubai. She's got a background of being the ICU nurse, and she's here to support the countries who require this product. So please, Michael, sorry, please you can start with the presentation.
Okay, very good. I will. I'll share my screen, or will Zarmina be sharing my presentation?
Zarmina? Zarmina will just do that. You can do that. You can do that. I think it may be better control of yours.
You're printing something?
Yeah, that's me.
Okay.
Okay, very good.
There you go.
Okay, so hello again. So my name is Michael Lombardi. My company is actually called Lombardi Undersea. We're a very small contract research company primarily, and have spent the last 20 plus years working on innovative solutions for underwater technology. A few months ago, watching the various media, global media surrounding COVID, I came across a few stories related to helmet-based ventilation in Italy, primarily.
When I clicked on it, it just went down.
And it struck me as quite interesting. So I saw emergency rooms with several individuals, all these little bubble helmets on. And it dawned on me that this is actually a very similar device is used in the diving world for the treatment of hyperbaric incidents. So with a little research and a few interesting connections along the road, I said, well, we have the expertise and connections to make a contribution to this, not knowing at all the extent of the problem at that point or how impactful this technology could be. So I reached out to Subsalve USA, who's they're a manufacturer of high performance inflatable products. They serve various defense markets, underwater research, commercial salvage, all kinds of interesting underwater market segments. But they had both the capacity and the very specialized manufacturing capabilities to take on the development of an oxygen treatment hood. So within a very, very short time frame, and when I say short, I mean from the time I sat down with Subsalve and said, hey, we should take this on, to working through prototypes, to having what we considered a pre-production unit, and then a production unit in the hands of several physicians to experiment with, was less than 2 weeks time. And then within another week to 2 weeks, I'd say we were in production and delivering significant numbers of these to both medical researchers as well as physicians who needed these emergently. So this is a significant part of Subsalve's COVID response. They're also engaged in producing other products for emergency response, but we'll focus on the hood in the interest of this webinar. So the specifications of the device are incredibly comparable to other helmet ventilation devices on the market, and that was done intentionally in the interest of being very quick to market. So the previous devices that are in production have an operating history, they're well established, the designs are recognized, there are good treatment protocols in place to put them to work. So we followed suit, and our specifications are, quite simply, it's a 12-inch diameter by 12-inch tall plastic bubble. It's very lightweight. It includes materials that are very similar to the other materials used in production, various PVCs, latex, silicone. The gas connections are compatible with the standard respiratory circuits in the community, or the standard 22 millimeter circuit connections. There's a service port for suction or administering medication. There's some straps, there's neck seal options, and so on. So most importantly, through identifying the key specifications were that we did want to be recognizable, but also differentiate with some key features. So one of SubSalve's strengths is in the RF welding manufacturing process. So by using RF welding, the device itself can be one piece, as compared to other devices, which are multiple pieces, where you actually have to assemble the hood, being the hood, sometimes the neck ring and the neck seal and other component parts to have a complete system. In our case, the device is one single piece out of the box that does not require any assembly on the part of the clinician when they receive the unit. So there's a few advantages to this. One is that it significantly reduces any inadvertent leakage from improper assembly. And additionally, being soft, it will add to patient comfort. So patients wearing the hood are able to lie back or recline without a rigid neck ring digging into their neck or shoulders and being uncomfortable. The device is produced with neck seals in either latex or silicone, and that is because, particularly in the US, some hospitals are latex free, given the risk of allergy, so we offer a silicone option. In the image of the device, this is the lower portion of the hood. You can see the two 22mm ports located towards the front. The red plugged port is what we call the service port, which is access for drinking or administering medications or for suction. The black area is the silicone or latex seal. They both look essentially identical, and those neck seals are they're offered in a range of sizes, but are also additionally trimmable for patient comfort. When the device is received, they're all clean, non-sterile, individually bagged. They include instructions for use, including an infographic provided courtesy Orca's team, who does beautiful graphics for this technology. And so that provides a few different setup options. And the devices are additionally provided with a neck seal sizing and care guide. So there's some instruction there on how to measure the patient's neck, appropriately fit the device to the patient, and trim the neck seal if it's needed. Now, making the connection to go from the patient interface or the hood itself to the gas supply is just as important as the hood itself or the supply system itself. And that's an important thing to recognize, and is becoming more clear in the community as the whole treatment is advanced. So the image here is one common configuration. It's not the only configuration. Simply on the inspiratory side, in this case, there's the ability to add a couple of oxygen lines, as well as a primary gas supply, be it from a high flow air source, BiPAP unit, ventilator, so on. On the expiratory side, there is a viral filter, and that's probably the most important from the COVID standpoint, because with this method of non-invasive ventilation, in addition to providing positive pressure and higher FiO2s for the patient, all of the gas that passes through the patient's environment goes through a filter. So that adds an additional layer of protection for the healthcare workers. Below the viral filter, you'll see a PEEP valve, and that's where we're able to regulate the pressure inside the hood. So this is one example of a circuit. There are multiple, which is a topic for what could be a quite involved debate and presentation. But these circuits can be configured to provide additional functions. So there's the ability to configure these to provide pressure relief, emergency breathing, and so on. So these oxygen hoods can be supplied from any number of gas sources. So wall gas, which I'm sure Dr. Patel will mention, and that's common at her institution. They're also supplied from BiPAP units, ventilators, and interestingly, in very recent weeks, by CPAP units. So it's very important as the end user to understand what your hospital infrastructure looks like and how you can best match up the respiratory limb circuits with the hood to deliver the treatment effectively. Okay, so I'll leave patient-specific questions and protocols to the physicians on board, but I'll mention that the guidelines can vary slightly based on the gas supply configuration. One key thing to point out is that we always want a minimum 60 liters per minute of flow through the hood, and that's to minimize the risk of carbon dioxide rebreathing. There have been publications that have proven this out, and as such, that's a really excellent benchmark for a minimum gas flow through the hood. And there are also great treatment protocol resources available at ARCA's site, helmetbasedventilation.com, and then I am collating additional resources related to the subsalve hood at oxygentreatmenthoods.com. So I'll just very, very briefly walk through a few methods that are commonly used. This is courtesy Dr. Patel, and I'll let her explain it in more detail, but illustrates that there is a method to supply the hoods with wall gas titration, meaning you have multiple air and oxygen supplies introduced into the hood at various flow rates to achieve the desired FiO2 and pressures in the hood. There's another method, this one is used by Penn Medicine, and they call it their Venturi method. So again, this is a function of the devices supplying the hood itself. They reference a few there, the Max Venturi unit, oxygen blenders, and so on. So if your particular institution favors these delivery methods, you would want to review Penn Medicine's guidelines carefully. This is a proposed method from Hamilton Medical, who manufactures ventilators. So again, this is used in institutions that have ventilators, but may want to use those for helmet ventilation rather than conventional endotracheal intubation. A fourth method, which is very interesting and may be very exciting for folks in this webinar, is that there's a CPAP method evolving very, very quickly. I'll point out that this is highly experimental. However, it's been currently accepted, excuse me, in Indonesia, Haiti, Ecuador, Nicaragua, and Nigeria over the last week or so. It has been proven out with physician input to be reasonably effective, but it does have limitations. So you can't achieve the full range of PEEP pressures that are of interest. So you're limited in PEEP pressures. However, you can elevate the FiO2 considerably with the correct oxygen supplies in place. So this technique, I think, will evolve and hopefully become widely adopted, at least in the interest of emergency use on a global scale in a short amount of time. Okay, so I'll just briefly touch on some safety considerations, and these are general. These aren't specific to the subsalve hood, but for helmet ventilation more generally. One is that these patients are quite sick, and they should not be unattended. So there should be some degree of direct attention to these patients at all times. Part of that is because of their condition. The other part of it is because these devices are an enclosed space, and if there were failure of the gas supply equipment, there's always risk of suffocation. So the device should not be used without qualified supervision. The device should certainly not be used on patients who are unresponsive or non-cooperative, and during use, the patient should be monitored, including frequent blood gas measurements. We should always monitor the helmet's pressure. That can be done by including a manometer in the patient circuit. And as I mentioned, we do not want to use the helmets with less than 60 liters per minute of flow. The patient should be aware of elevated noise. They should also be aware of aerophagia and those risks associated with swallowing air. And from a physician standpoint, we want to be aware of oxygen toxicity. Now, there's nothing out of the ordinary with using the hoods that would increase oxygen toxicity any more than with other modes of non-invasive ventilation. So you want to follow your standard guidelines for when the patient's exposed to higher than normal levels of oxygen. You should be aware that lungs can be damaged by elevated pressures. So a blockage of the outlet can lead to excess pressure. So it's very important on that limb I illustrated where the PEEP valve was to make sure that filter does not become clogged. So in environments where there's particularly high humidity, we want to make sure that the filter gets changed regularly. There are, as I mentioned, circuit configurations which can place that filter up rather than down, so it doesn't become a source for pooled fluids, be it condensate, vomit, and anything else that's coming out of the hood that could clog that filter could become a problem. So we want to be aware of that as we set this system up. And I guess, as I mentioned, there is a risk of suffocation if the patient were left alone and there was significant failure of the overall system. You need to be aware of that. And some rebreathing may occur. So that emphasizes the need to have a high flow at all times. This is a high flow situation, high flow device generally, but it's very important to maintain that 60 liters per minute flow at a minimum. And then, as with all medical devices, we'd want to discontinue using the device if the patient had any adverse reaction. So that's a very quick overview, and I think there are multiple areas of this that would warrant significant discussion at another time, particularly for each specific treatment, and possibly how to configure the limb circuit specifically. But I think I will leave my part there for the time being, and we can come back to questions after everyone else presents.
That was very useful, Michael. I think we have got a very active audience, and they're really enjoying listening to what your presentation had to say. And I could already see that lots of questions are coming in, and I could see that Zora from AGM Pharmaceuticals have already come up with very nice questions. And I think Dr. Patel is already busy answering them. So I wanted to assure everybody that we will leave lots of time towards the end to answer all and as many questions as we can address, and we'll try and get to them. In continuation of what you talked about the product, Dr. Patel, you have worked on this product, and with your expert on NIV, we would like to hear from you your experience and your suggestions.
Sure, thank you. I'm going to share my screen here.
Do you mind quickly telling us a couple of lines about yourself, because the audience doesn't know you? Because
Sure.
You're very humble.
Sure, I'm a pulmonary critical care physician at the University of Chicago, and I conduct clinical trials in the ICU, specifically engaged in mitigating the complications of being on a ventilator. So one of the clinical trials we conducted back in 2012 and then published in JAMA in 2016 was related to helmet ventilation, specifically using it for patients with hypoxemic respiratory failure. So my presentation today is going to go through the data that suggests that helmet non-invasive ventilation has greater efficacy for patients with hypoxemia. So I have no conflicts of interest to disclose. We know that traditional non-invasive ventilation delivered by a face mask, seen in this picture here, can obviate the need for endotracheal intubation. And when it does that, it does avoid the complications of being on a ventilator. Data has suggested that the benefits are most compelling, specifically for two indications, COPD exacerbations and cardiogenic pulmonary edema. But what we know is that when patients receive non-invasive ventilation by face mask when they have hypoxemia, either from pneumonia or acute respiratory distress syndrome, their failure rates on this approach are quite high, approaching 50% and above. And so it was a coin flip that when you apply face mask NIV to patients with hypoxemia, that they will prevent an intubation. And we hypothesized that the failure rates with face mask were quite high because often when patients are hypoxemic, they need higher levels of pressure or higher levels of PEEP. And it is at these high pressures that there's excessive air leak around the mask. And then patients become intolerant of this approach and require endotracheal intubation. And so we wondered whether an alternative device known as the helmet, which is a transparent hood that goes over the head of the patient. The seal is at the neck such that it can support substantially higher pressures without any leak. The helmet then is pressurized and then affixed to the patient using arm straps. And then the PEEP can be adjusted to as high as 20 centimeters of water or higher without substantial leak. The patient, in addition, has an unobstructed view of the environment, and so the mask doesn't cover the nose and the mouth. It feels as if you're pressurizing the cabin on an airplane. And so often as you apply it, the patient will sort of equalize their ears and swallow, and then afterwards have an unobstructed view of the ICU. They're able to sit in a chair, they're able to mobilize with this approach, and they're able to be free of sedation, and so they can participate in their care. So this is the helmet that we used in our clinical trial. So we conducted a single center randomized clinical trial where we took patients who had acute respiratory distress syndrome, and the providers had already started non-invasive ventilation using a face mask. We waited 8 hours specifically to make sure that these patients were severe enough that they required prolonged use of non-invasive ventilation. And what we did was that half of the patients were then randomized to receive helmet NIV, in which they switched from the face mask interface to a helmet. And then the other patients randomized to the control group remained on the face mask interface. And in work that we published in JAMA, we found that the rate of endotracheal intubation was 61% for patients who were randomized to the traditional face mask versus 18% with the helmet. When we looked at the reasons why patients were intubated in the face mask group, it was primarily because they had worsening hypoxemia. So this approach was unable to improve their gas exchange. In comparison, for helmet, it usually was patients were intubated because their mental status had deteriorated and there was concern that they were not able to protect their airway. So the traditional contraindications for NIV was the reason that the patient was not maintained on helmet. And in addition, there were more ventilator-free days as well. And what we also found was that our 90-day survival was substantially improved with helmet NIV by 22%, such that if you applied helmet to 5 patients, you would prevent 1 death. And we found that what we hypothesized was that helmet's efficacy was based on the fact that it could achieve higher PEEP was true. So patients who were randomized to helmet, at least 50% of them were able to achieve a PEEP of 10 and above without any leak to support their respiratory failure. In comparison with face mask NIV, only about a quarter of patients were able to achieve a double-digit PEEP. Obviously, there's cautions and limitations whenever you apply data from a single center clinical trial. There is, of course, lots of dead space with the helmet, and so there's risk of CO2 rebreathing. There's plenty of physiologic studies looking at ways to mitigate this risk. One is using a fresh gas flow of at least 60 liters to prevent CO2 rebreathing. In addition, obviously, there's a clinician learning curve. So as your institutions start using helmet ventilation, it's important to start in a low risk population. So what does low risk mean? I would say if a patient's requiring 6 liters of oxygen and transitioning to non-rebreather, that might be the population of patients that you may want to try for, where this patient isn't necessarily someone who requires immediate intubation, but may be preventing an intubation earlier in their course. Because of the nature of the intervention, we couldn't be blinded to the results, as well as a single center trial, makes concerns about generalizability. This clinical trial was stopped early, specifically because there were data coming out that face mask non-invasive ventilation in patients with ARDS actually increases harm. And so we couldn't continue to randomize patients to the control arm. We used a ventilator to deliver helmet NIV. And so when we think about its use for the COVID era where we're trying to spare ventilators, the efficacy is not tested in that approach. However, as Mike had detailed, there are ways to deliver continuous positive airway pressure or PEEP without a ventilator. And obviously it was studied in patients with a wide variety of ARDS. There was no COVID at that time, so the efficacy with COVID may be substantially less because of the severity of the disease. But I would like to call to attention a recent systematic review and meta-analysis published in JAMA a little over 10 days ago, looking at all the trials that compare different modes of oxygen support. So specifically face mask non-invasive ventilation, high flow nasal cannula, and helmet. And then what they did is that they did a sophisticated meta-analysis where even if there wasn't a clinical trial comparing two modes of oxygen support, they used data from other clinical trials to suggest whether they're efficacious or not. And so as you can see, there's no clinical trial comparing helmet to high flow, but if helmet was compared to something that was also compared to high flow, they used those data to make a logical guess. And what you can see from this forest plot down here, in terms of endotracheal intubation, helmet clearly prevents endotracheal intubation based on data from over 300 patients. In addition, when you compare helmet to other modes of non-invasive oxygen support, it clearly is able to improve your risk of endotracheal intubation. And then when you look also at all-cause mortality, again, helmet non-invasive ventilation reduces the chances of dying from your respiratory failure. And when you compare helmet to either face mask or to high flow nasal oxygen, there's also data to suggest that perhaps it favors this approach. And so in early reports out of Italy where patients were being put on helmet ventilation as a prevention of intubation strategy, we found that from speaking to Italian physicians that it could prevent intubation about 20 to 30% of the time. I will say that they were using helmet non-invasive ventilation specifically when patients were failing high flow nasal cannula. And so this was a particularly high-risk population, and we have been using this helmet non-invasive ventilation in a similar approach at University of Chicago, and I've seen this similar efficacy. And also, they used helmet NIV in a ventilator-sparing mode, meaning the helmet was not attached to a ventilator; it was attached to multiple different devices, as detailed by Mike previously. Why helmet seems attractive specifically for COVID. Helmet, because of its fidelity of the seal, leads to less aerosolization and healthcare worker exposure than any other non-invasive device. And so this is a physiologic study where a helmet was applied to a mannequin, smoke particles were put into the helmet, and then photographed. And so as you can see here, the smoke particles are contained within the helmet and not leaking out. In comparison to a full face mask NIV, you can see on the exhalation port, there's a jet of smoke particles really released by that mask. And so this becomes important when we think about sparing exposure to healthcare workers, which are also in limited supply. In addition, there's factors that contribute to ventilator shortage due to COVID because some believe there's no other safe options for non-invasive oxygen support. And so because of the risk of healthcare exposure, healthcare worker exposure with face mask NIV, even in indications that are not COVID related, at least in the United States, when patients presented to the emergency room or to the hospital with non-COVID illness like COPD or cardiogenic pulmonary edema, indications that specifically would require face mask NIV, because you could not rule out, or the testing was not fast enough to rule out whether the patient had COVID or not, these patients would then end up intubated. And so now you had one less ventilator because of that approach. In addition, other institutions are concerned about the aerosolization related to high flow nasal cannula. And so then the threshold to intubate patients became when they became hypoxic on non-rebreather alone. And therefore, you used up a ventilator for a lower threshold patient than you normally would, just because you were limited by the different strategies that you typically would use. And so ventilator overuse became a substantial problem during the COVID pandemic. And so just to summarize, I think I've shown some data that says that helmet non-invasive ventilation can provide a safe option for oxygen support, and specifically in terms of mitigating the risk to the healthcare worker. There are prior data that suggests its efficacy to prevent intubation and also death in patients with acute hypoxemic respiratory failure. It can also help mitigate our over-reliance on a ventilator because we have limited options otherwise in terms of oxygen support strategies. And then, we're grateful to SubSalve in order to provide some helmets because of the limited manufacturing that was available at the United States at the time. So that's the data behind using helmet NIV.
Thank you very much. Thank you very much, Dr. Patel. We've got Dr. Lukmani, who also plays a very important role, and they've done a lot with Humanity First. So I think we will open the question, and Dr. Patel, there are lots of questions piling up for you as well. So I'm going to come back to you again on this. Meanwhile, Dr. Lukmani, would you like to say a few words?
Yeah, thank you, Raza, for inviting me. I think ever since the COVID hit, Humanity First, which is a welfare organization, helps in disasters and in peacetime. We started getting active, and we started with opportunities to see how we can help people who are in dire need of help. So we come across this project which was going on, and we wanted to see how we can help helmet ventilation to be implemented, because in America as well, there is no, it was not used, even though it was very effective in other parts of the world. So we started helping the company. We got some support from Apple. And then we looked at different types of helmets, and we thought that SubSalve helmet was the best. It's easy. It's only one piece. So we started a research project, actually, which Dr. Patel is also helping, which is just in the beginning stages, where we got 15 different hospitals where Humanity First physicians work. And we sent them the helmets, so they have initially just testing them out, and from there we are going to start a research project, multi-center, to prove that this is a great new technology which should be used not only in America but also rest of the world, where their availability of ventilators are not good. Even there, when there is an availability of ventilators, as you looked at the data, it does have a significant improvement in mortality and in rate of intubations. So it's a great thing, I think, for long term. It's just is new and needs to be implemented. And I think it's COVID time. This is a good time to actually get it to use all over the world. So that's all I have to say. I'm part of Humanity First, which is a philanthropic organization. We have no interest in this product other than the fact that we really like patients to get better. And I think this is going to be a great opportunity for the countries where their ventilators are in short supply and patients' load is going up, to help people. So all we are here to just help them in any way that we can. That's all I have to say.
Thank you. Thank you very much, Dr. Lukmani. I wanted the audience to also realize that the entire effort is not only about products development, product sales, and commercial. A lot of this work is being done keeping humanity first, literally, not only just as an organization. And that takes me to Orica, who does a lot of work for humanity. And I'd like to read what wonderful things that she's been involved with. Orica have been involved in the successful testing of the helmet ventilators in the ICU at the University of Chicago during a 3-year trial study. While in pursuit of a Master's of Science in Nursing, Acute Care Nurse Practitioner degree at Rush University College of Nursing, she wrote her capstone paper, Non-Invasive Positive Pressure Ventilation, for treatment of acute respiratory failure, an immunocompromised patient, based on her experience with ventilation via the helmet. So we are very lucky that we have somebody like Orica right now with us, who has a heart of gold for serving humanity, and at the same time experience on the product, working with somebody as dedicated as Dr. Patel on this subject, sitting with us talking about how we can use this product to its best in this part of the world, and how we can create this bridge between subsalve and the end users through all our services and support together. So Orica, over to you.
Thank you very much for having me here, and thank you for a beautiful introduction. I was actually lucky to work at University of Chicago with the team who did the study, and this was the first time I saw a helmet-based ventilation. So when the pandemic started, back in March, my husband and my sister-in-law decided to make a website where we will put all the information for the clinicians, manufacturers, and connect them, and also investors. So this is how the helmetbasedventilation.com started. And I'm just so passionate about this setup. And I know the great benefits of non-invasive ventilation, especially for the COVID patients. I'm going to share the screen right now where you can see our website, which is updated on a daily basis. We have the list of all the research papers, the recent ones that are about the CPAP setup or ventilator setup or BiPAP setup for the helmet. Also, the very important part of the helmet-based ventilation is actually guidelines, protocols, education. And this is where you can see all the protocols and guidelines, which are actually in a smart procedure setup. It's a mobile application for phones and for the tablets. Here you can see an example that is a smart procedure for the helmet-based ventilation that is based on Dr. Patel's video. And it's a very easy tool to use where you can go step by step on setting it up and looking at all the indications and all the troubleshooting and weaning off sections for that system. Also, I'm very glad to have a team who made all these infographics, which are very easy to look at and visualize what the helmet-based ventilation is and how it can help the humanity. On a daily basis, I try to make as many videos as possible where I can talk about the helmets, about the ones that are made in US. And right now, my latest video is about helmets, 5 helmets that are made in US. And this is where I want to say that the subsalve helmet is very easy to use. It's a one piece and it is very comfortable to wear on. So like Mike Lombardi explained at the beginning, it doesn't have any hard parts, so the patient is able to change his position in the bed and stay comfortable. Now, based on my experience as a nurse and patient care manager, I can say that non-invasive ventilation can be very difficult with the face mask and BiPAP. The face mask come in different sizes, so the patient's face is also different shapes. And to make sure that there's a minimum leak it takes sometimes about 20-30 minutes to fit that face mask on a patient. And when you have somebody in a respiratory distress, those 20-30 minutes is a big deal. So with the helmet, this is not the issue. When you put the helmet on a patient, it inflates very quickly, and the leak is none to minimum. So we as nurses in the unit, we notice that right away. And I'm just a champion for the helmet-based ventilation. And here in my website, you will find all the latest data, all the protocols, and all these applications are actually for free, so please feel free to share with your team, use them, and learn. So to make the helmet ventilation successful, you definitely need to make sure that you go through all the steps, you learn the protocols, try it, and then after practicing it so many times, it's going to be a very easy system to use, to set up. And actually monitoring patients with the COVID patients, you want to make sure that you monitor them very closely for the first 1-2 hours, because this is when you will see if the patient will benefit from this system, or we need to be intubated. So this is about this big mission that I hope will help the rest of the world. And I can tell you now that a lot of other countries are developing their helmets, and we're trying to implement in their health system. And at this moment, I can say that SubSelf helmet is very easy to use. It can be cleaned and used for multiple patients, and it is the most comfortable helmet that is made in US.
Thank you. Thank you very much, Dr. Aurika. This was very helpful, and thank you very much for what you're doing for humanity. Emma, this is really amazing, because now all of this is about today, the very famous phrase, the last mile delivery. So we've got an amazing group of people who have gotten together, created a product. We've got an amazing team of professionals who have done the trials and are really confident about the positive outcome of these products. Now we're talking about how to get these products to actually benefit the people in this part of the world where we don't have money for ventilators. It's not only a choice of product of what kind of ventilators. We really cannot reach out to our large communities. And especially after knowing that these ventilators are not really the only option, right, at least in the beginning, we may have a pre-ventilator solution where we could use the non-invasive ventilator first. I want to ask you, how are you going to be able to help us, and what is your view? But before that, I would want to quickly read your bio to the community joining us now, so that all the participants know. Emma Macbeth, who's head of clinical operations at the Health Bank. Emma has worked in the region for over a decade, so she does understand this region and the nationalities that are living in this region. So Dubai has over 150 nationalities represented from around the world, and pretty much fully covers the region here. Emma has been involved with the region for over a decade and is responsible for nursing practice across all the health banks, including home care, health management, telemonitoring, nutrition, and nursing quality. Her nursing career has been dedicated to creating high quality, reliable system of care and developing the next generation of nurses and healthcare professionals to lead in these ever-changing times. So, Nema, over to you. Tell us about it.
Wow, that's something hard to follow.
And I just want to also tell you that two things I want to tell you. One is that you really have to speak louder because we don't seem to be able to hear you clearly.
Okay.
Second thing is that we are now getting ready for answering a lot of questions. So we have a lot of questions. So you can tell us about it and let me know so that we can start taking the question from the regional point of view.
I think we've lost Mr. Raza.
Yes,
Hello?
Emma, over to you. Please go ahead. Tell
Oh,
us.
sorry, there was a bit of a break there. I won't take up much time, so I feel a bit of a fake attendee sitting with all of these amazing people. So, and Orica, I was visiting your website over the past few days, and you know, I really learned a lot. Even though I'm an ICU background, it's very exciting what you're doing. So, you know, for us in the health bank and generally in the region, you know, there's obviously a lot of things that we can do here. Although we come from economically quite affluent, if you like, area in the UAE, we certainly, that isn't every hospital and every country surrounding. So, you know, for me as an ICU nurse, I can see both the benefit to the patient, but also for protecting healthcare workers. And as we've discussed, protecting those you know, vital ventilators for the patients that really need it. So for me, it's been so exciting listening to everybody, you know, that particularly all of the data which is preventing these patients from being intubated, which we know is unfortunately a slippery slope. Once they're intubated with COVID in particular, you know, their chance of survival is pretty slim. So, you know, thank you for inviting me. I'll let you go straight to the questions, Mr. Raza, because I think there's a lot of people that are waiting to ask. I think, are we frozen?
Thank you very much.
No,
We have
you
very
are.
interesting questions from a lot of people. And if it's okay, I'm going to start reading some questions right away. So number one question, which I find it very interesting, is from Dr. Aziz Giovanni. Can it be used in isolation center for COVID patients where only oxygen cylinders are available with flow of less than 10 LPM? Dr. Bhakti or Michael, I don't know who would be the right person to answer. Dr. Bhakti,
Yeah,
with
so
you?
the total gas flow within the helmet has to be at least 60 liters. And so if only 10 liters is oxygen, then the rest of it, the 50 liters, would have to be room air. And so you wouldn't be delivering a high FiO2 to these patients. And so you could try it, but it's less likely that you'd be able to deliver high levels of FiO2 just because of the low oxygen supply.
Okay. Dr. Lombardi, do you have any comments on that?
No, I agree with Dr. Patel entirely. So the high flow from a safety standpoint, the high flow is absolutely the key piece here. So maintaining that 60 liters per minute flow is absolutely necessary to reduce the risk of carbon dioxide rebreathing. So when you consider that, you know, that 60 liters needs to be made up from any number of supplies. So, you know, for instance, if you had 20 or 30 liters of oxygen backed up with air, then you would have a solution with high FiO2 as well as the PEEP you may need for the treatment. So that's very important to consider when setting up these centers.
Two other questions. Using it with a BiPAP machine and using it with CPAP, what are your findings? Dr. Patel?
So for the CPAP mode, it's actually, I think, less risk of causing high tidal volumes for the patient and exacerbating the lung injury because you're primarily just recruiting the lung and you're not delivering any inspiratory support to augment the tidal volume. In BiPAP modes, that's the main risk. Often, if you use face mask non-invasive ventilation, you rely on BiPAP because usually the work of breathing is so high that the only way to improve the patient's work of breathing is to give them BiPAP, increase the pressure support. But in helmet, especially in CPAP mode, the addition of inspiratory pressure is not necessarily needed because once you recruit the lung, the patient's spontaneous breathing at higher levels of PEEP traditionally puts them at less risk of high levels of tidal volume. So I'll put in the chat a paper published in the American Journal of Respiratory and Critical Care Medicine looking at the work of breathing related to CPAP mode for a helmet and you can see that it's much less than compared to high flow. And so you don't necessarily need bi-level. If you have a device that only delivers bi-level, there are physiologic studies that suggest that you may have to increase the inspiratory pressure, not because the patient needs a higher tidal volume with helmet, but just so that the fresh gas flow within the helmet is at least 60 liters. And so when you deliver the additional pressure support, it's to inflate the helmet, and it's not necessarily to give a high tidal volume. The tidal volume is unknowable in terms of how much of the air that goes into the helmet is actually being inhaled by the patient compared to what is necessary to inflate the helmet. And so that part is still under investigation. So what I would say is I would use CPAP mode specifically for using for COVID.
Thank you. We have a question. I think, Orica, you may be the person taking care of a lot of patients. So people, Dr. Hassan Zahir has asked a question. Can you throw some light on the patient compliance? How do patients eat, drink, discomfort, sleep issues? How long can you use one hood?
So how long it can be used based on feedback from Italians, patients can be on it for 2 weeks. This is for the COVID patients. Definitely we take some breaks if needed, but usually with the helmet-based ventilation, patient feels so comfortable, so we don't have to take breaks like we would take with the face mask BiPAP machine. Now with drinking and eating, so there's a patient access port. So you wanted to give, you can give liquid food or water. Again, for the patients, they need to learn how to do it because of all this pressure in the helmet. You want to make sure that they know how to seal their lips around the straw and take the sip and not to open the mouth because they may end up getting, spray of the liquid, or it's just very uncomfortable when you have all this pressure. So again, there's a learning curve for the patient too. With the great staff at the bedside, you can, help the patient to learn these steps and make sure that it's safe for them to take fluids. Also, you can suction the patient through the same patient access port. Remove the helmet is easy. You just have to make sure that you have 2 people who take the helmet off, so it is much easier for the patient and for the staff. The sleep, again, it is, you can adjust the pillows in the back, and with the sub-self helmet, because you don't have a hard ring around the neck, it is much easier for the patient to lay back, so nothing is pressing on the neck. Also, where the input, the in and out of the air access is, when you connect all the filters, the PEEP valve, and the oxygen supply, some of it can bother the patient on the chest. So when you move the head up and down, it's gonna, press it on your chest, so it is uncomfortable. But this is why we're adding the dead space tubing, so it doesn't bother the patient. When we talk about the noise, you can use the earplugs. For some patients, it actually feels more like a white noise, so it makes even more comfortable to fall asleep. Now about the skin breakdowns, I do hear that question a lot because, as you know, with the BiPAP, the face mask setup, patients develop a lot of skin breakdown around the nose and the cheeks. So with the helmet, there's still a risk of developing the skin breakdown around the neck area. So you want to make sure that you always check for the neck. Also underarms, where the underarm straps goes from all this pressure. So again, make sure that you have some soft padding in the armpits so it doesn't bother the patient. So, but all these skin breakdowns are much less comparing to the face mask. Another question that I hear all the time is the claustrophobia. Actually, with the helmet, patients have less risk of claustrophobia because you have a clear view around you, nothing is touching your face. So comparing to the face mask, it is less common. I hope I answered the questions. If I missed something, please send a message. I will type my answer.
Very good. I think it answered quite elaborately. However, if any of our viewers want to ask more questions, I'm going to leave a number behind towards the end where you can all ask us all your queries and we'll go. I want to respect everybody's time, so I think let's have a hard stop in the next 7 minutes or so. So we'll take a few more questions, which one of the important ones is, what are the contraindication of this NIV? Because we've heard all the good things that it could do, but what should we be worried about? That's one thing that it really is concerned. The another problem is people are asking at what point the patient should be switched to ICU or invasive ventilation. So that decision. So these two questions, I would like to open it, and then towards the end of the or after these two questions, I have a very interesting scenario that I've been requested for since last couple of days. So I'll discuss that with you if it's even possible or not.
So in terms of the contraindications, they're the same ones that you would apply to any non-invasive device. So if the patient has impending cardiopulmonary arrest, meaning you're going to start CPR, this is not the patient to put an IV on. If they have an upper airway obstruction like stridor or some upper airway mass, you don't want to put a helmet on them. They have intractable vomiting or hemoptysis, and there's risk of aspiration of that. They should probably just get intubated. If they go into a coma, so if their Glasgow coma score goes to 8 or lower, then you would intubate them. In the clinical trial, we excluded patients who had high intracranial pressure, and so we did not include them in the study. We also wouldn't put a helmet on someone if they were pregnant, because there's special vulnerable populations that we haven't used helmet for, but physiologically there wouldn't be a necessary reason why a pregnant person couldn't wear a helmet, but we just didn't include them in the clinical trial. In terms of the setting to use helmet NIV, this is a cultural thing. So in the United States in general, non-invasive ventilation is typically done in the ICU because regardless of the interface, just for evaluation of the patient. I will say in Italy and in France, they do use helmets very frequently because outside that setting, because they're confident in their use. And so they use them on the ward, in the ER, as well as sometimes even in an ambulance. And there's multiple case series explaining that. In general, when you're thinking about should the patient come to the ICU, if your institution allows NIV on the floor, would be if the patient's requiring more than 50% oxygen, if their PF ratio is less than 200, I would suggest that they probably are at high risk of getting intubated and therefore should be in the ICU. In terms of the indications of when to intubate, in general, we wait, we place the patient on helmet, and if after adjusting the settings, and we find that their hypoxemia, meaning their saturation is not 88 and above, or their respiratory rate is greater than the mid-30s, and that's after titration. So within 2 hours, if we don't see an improvement, we intubate the patient. And this obviously, if the patient deteriorates in any way in terms of their hypoxemia, meaning not saturating at least 88 to 90%, or breathing in the mid-30s and higher, we typically intubate. So these were the predetermined intubation criteria we use in the clinical trial.
Thank you. So I'm going to ask you a question which is brewing in this part of the world, but I'm getting calls from India, Pakistan, also from Indonesia, and saying that South Africa as well, that a lot of people, especially people who do not feel like they may get access to hospital beds, there is a shortage in reputable hospitals. They're overloaded with patients coming in every now and then. So a lot of people are creating their own emergency backup. I know people personally who actually have gone to the extent of having their own ventilators, full-fledged ventilators at home, with the facility set up at home in case they run short of hospital space. Right now, a lot of people are concerned about a few things: getting hospital-acquired infections, plus their family members and anybody coming in and out is also very highly exposed, plus the quality of care, and to look at it above all, you have a bed. So if you have a bed, you're exposed to a lot more infection, you're not 100% confident about the quality of care, and they want to ensure that at home. So a lot of people are saying we're setting up our own emergency unit at home, and we would like to have our own BiPAP or CPAP with the non-invasive ventilator hood, and to have support from the local doctors and nurses, and we do it at home. Do you think it's possible for people to do something like this?
I can take that question. This is a sensitive one that's come up in our interaction with various people around the world in these resource-limited areas. And, part of this is an ethical dilemma where the developed world has very strict standards of practice in medical care. And in light of the emergency, it may be appropriate to lax that to some extent, but ultimately somebody has to make informed decisions about administering that care. And so I think education is going to be a key part to how we implement that. Over the past month or so, I've been involved in a local project, a research project that's tried to characterize circuits using conventional at-home CPAP units, modified slightly to supply an oxygen hood. It can be done. It can be done effectively. However, you still need a sufficient supply of oxygen. And that will be a challenge, particularly in a home-based environment or more remote field areas. So, I think in terms of implementing this off the grid in resource-limited areas, yes, it can be done. I think personally, from an ethical standpoint, I think it should be done. I really don't think there's any other option, because certainly, more expensive ventilation equipment won't make it into these areas. But I think, we all have to come together and determine the best path to educate people on how to do that safely.
All right. Well, thank you very much. I think as we go along, there will be many queries, many questions, and we are all here to support this big family trying to promote the use of non-invasive ventilators to save lives. I would ask any of you who have any questions, any queries, any concerns, to feel free to contact Zarmin Jafar on the email mentioned there. You can take a screenshot and save this number and contact us. It's available. And if there are any queries for your region, please feel free to contact us on it. This is not really something that I want to deal with on the commercial issue right now. So commercially, if there are any queries also for orders or for pricing and all that, because some questions were coming there, please contact the numbers and they will contact you back. Thank you very much for everybody to come in time, give us your time and share your knowledge and experience with a group of people who are willing and keen to help people around in their region. And we hope that we can all make a difference. Thank you very much.
Thank you.
Bye-bye.